like to introduce our panelists. Thank you for being here. First, we have Alderman James Cappleman of the 46th Ward. Thank you for being here. We have Deputy Chief Sacluti from Evanston. Thank you for being here. And then Renee, Labrana. Renee is a business owner and very involved in the Rogers Park community, so thanks for being here. And before we really dive in, I want to talk a little bit about what Trilogy does. We're a nonprofit. We're a mission-driven organization. Our mission is to help people who have mental illness really recover and lead more independent lives. So I'll give you just kind of a snapshot about what we do. This, as Erica pointed out, this room that we're in is our drop-in center. We have two of these, one here in Rogers Park and one in Chatham. So the other location is at 85th and State Street, way down on the south side. Trilogy serves the whole city. We've been in this building since, I think, 1992. So a lot of people think of Trilogy as being only on the north side, but we're all over the city. Mayor Biss has just joined us on the end, and like I said, this is a partnership with Evanston as well. And so we've been working for over a year on really getting this operational and together. So Trilogy we have about a $50 million budget. About 75% of what we do is what we call intensive outreach. So we have outreach teams that meet in the morning, talk about what their schedule, and then they go out into the community. We have people who come here for the drop-in center, but many more of our services happen outside of this building, in people's apartments, in shelters, at doctor's appointments. So that's kind of a large part of what we do. We have a very robust employment program, so we help people find competitive work. We also do child and adolescent therapy and adult therapy, kind of similar to what you might get with a commercial insurance plan. Hour-a-week therapy. We have psychiatry. We have an integrated health program. Mary talked a little bit about that, but we actually have a health clinic in this building. So we have primary care providers and psychiatrists in the same clinic, helping to really serve the whole person in a more effective way. So that's what we've had our integrated health clinic for 10 years, and it's just the best way to serve people who have both a mental illness and are medically complex. So that is very, very exciting. We want to do more of that, actually. And the crisis program is one of our newer programs. So I will let Sarah take over.
We here in Chicago definitely need alternatives to calling 911 in mental health crises. If you call 911, what you're going to get is maybe a paramedic if somebody's injured, right? But more oftentimes you're going to get police as a first responder. It's not their primary experience, and they're meant to be law enforcement.
Most of the time when someone is in a mental health crisis, they are not committing any sort of crime.
We want to make sure that these individuals get the care that they need and the treatment that they need. And it just makes sense to have people that are trained in mental health support, that are gifted crisis responders, be able to help people when they're in mental health crisis.
FACT stands for First Response Alternative Crisis Team.
The FACT team launched early 2022. We have a 1-800 number people could call if they're in a crisis. Family and friends can also call that number, or a community member, if someone in the community is in crisis, can call that number as well.
We work with the Evanston Police Department, Skokie Police Department, and Chicago Police Department. And also we work very closely with the Alder People's Office.
Before the FACT program, my staff didn't have anybody to call. I didn't have anybody to call. So it was really a blessing for Trilogy to receive the state funding, knowing that we have this really desperate need for these alternative crisis response networks.
Any sort of crisis, mental health crisis, or resource crisis is an appropriate reason to call the FACT line.
Trilogy Mobile Crisis Line, this is Mimi, how can I help you?
When a call comes into the FACT line, the dispatcher will listen and then determine if a mobile crisis response is needed.
If it's not something that's acute that needs to be addressed right now. We might schedule a visit with you tomorrow to help you sign up for Medicaid or connecting you with the needed resource that will provide what you need.
If it does need a mobile crisis response, we send 2 staff members out to address the situation.
About 95% of our calls do require an in-person response.
Sometimes we'll meet them in their home if that's appropriate. Sometimes we'll meet them at the park or at a coffee shop.
It also depends on what the presentation is. Are they extremely escalated? It really does vary, so we do kind of have to be ready for anything.
When we go out on a call, our team's goal is to really be able to acknowledge what is needed for that person.
You know, we don't come with flashing lights. We are there as ourselves, and I think that can make people feel more comfortable. We really want to be able to, de-escalate without having to take somebody to the hospital. Our crisis response team is made up of 2 individuals, your crisis counselor, and then a peer engagement specialist.
The reason that we have peers on our team is because they have lived experience.
When someone can say, hey, I've been there, I know what you're going through because I've truly lived it myself, it's really the best way that we can build rapport with people, and it's just so important. The response goes well if we have been able to get them the help that they need, whether that's staying in the community or whether that's, being hospitalized. Even when people are hospitalized, we continue to follow up with them.
We follow up with the hospital, we talk with the social workers so they transition into the community in the best way possible.
Crisis isn't only a one-time thing or one-type situation, but it's the long-term care that is really important to help prevent future crises from happening.
So I'm Sarah Fletcher. I am our Executive Clinical Director here at Trilogy. I just want to say thank you again so much for everybody coming tonight. A couple of years ago, I feel like we couldn't have all been together here in person. And I think there's something really special about being able to have this conversation in person all together. So thank you all for being here. I also think it's a lot, the pandemic as well as other social crises that sort of happened in 2020 that have brought us somewhat to where we are today. Have been a big contributor to the additional funding going into programs that have allowed us to build our FACT program, as well as other programs like this across the country. So I'm going to jump in a little bit to talking about why we built the FACT program here at Trilogy and what that has looked like. But first I want to set the context a little bit to be thinking about sort of what was happening a year ago, around when we sort of started to build this program. So we all know that the pandemic really put additional stress on already strained social networks, both locally and nationally. And we saw an uptick in deaths by suicide in communities of color, as well as growing calls locally that really mirrored demands that we saw nationally around interactions and responses, especially in communities of color, in interactions with police. And so kind of wanting some different kind of alternatives to some of how that was going. There was also an increased call to improve and streamline our response to suicide across the nation. So we've had the national hotline for a long time, but really needing to be able to streamline that in a different way, which led to some of the development of the 988 number, which Susan kind of referenced earlier. But this kind of gives a really good kind of side-by-side of what 911 kind of was built for, is made for, and then 988 and sort of what that's meant to do. And a big part of the rollout of 988 was around really having a centralized way for folks to be able to get that emergency mental health care. Instead of, if I'm in Michigan and having an emergency health crisis, I've got to try to find the local number and figure out what to do. And 988 really gives us a nationwide way of getting that resource in the moment, kind of in the same way that we would for a physical health crisis. 988 rolled out nationally July 2022. It's still got a ways to go, I think, in terms of just that resource getting built out to really what the vision is for that across the nation. But it did really provide a lot of additional funding for places like Trilogy. All of the call centers that used to be the national suicide hotlines are what have been sort of transformed into the call centers that receive the 988 calls now. However, I think with just that expansion of 988, we really needed to increase the amount of staffing for those call centers, building new call centers, and then having the staff to be able to go out and respond to those calls that they're getting in, if that's the level of response that's needed. So that's really where a lot of the additional funding has come from, to be able to build programs like that. I'm not going to read the whole slide for you because I feel like you all can do that on your own. That's kind of the background around 988 and 911. I will say here in Illinois too, there's still a lot of development of what that's going to look like for 911 calls to be able to kind of get routed to 988 or have some interaction when it is a mental health call coming in. So kind of watch this space. I feel like there's still just a lot being developed in that area. So I'm going to go through kind of some overall outcomes and stats for the FACT program. We have been in existence for over a year. So we started the program in January 2022. It was initially and continues to be funded through DHS Division of Mental Health. It's the Program 590 grant. So that's kind of how we're able to pay to get the program up and running, as well as kind of ongoing staffing, and then we also bill Medicaid for some of the services that we provide through the program as well. We are 24/7 and very proud of that fact. I feel like that was a big build up to get there, so I want to say thank you to all the staff that are here too for making that happen. But our main areas are listed up there, so we are primarily, our mobile response part of the program is in Rogers Park, Westridge, Edgewater, Uptown, Evanston, and Skokie. That's kind of where we go out to. There's a little overlap with some other programs across the city, and we really have tried to interact well, collaborate when we get calls from other places to make sure that gets referred out to the right team, as well as vice versa if other folks get a call to kind of send that our way. So we have served 392,000 people, and our overall service covers 28 square miles, I think is what it was overall. So we receive, most of the calls that we receive or have received so far are through our specific 1-800 crisis number that's listed up there. Eventually, hopefully that will sort of shift to receive more calls directly from 988. But that 1-800 number is available for clients themselves, for family members, for even staff kind of within Trilogy if they need some additional support. Really anybody that is experiencing mental health crisis or has somebody that they're worried about can call. We also get a decent amount of calls kind of from the community, seeing something or seeing someone that does not appear to be doing well. They might call and we might try to go out and see if we can assess and just see what's going on. Anytime that we do respond in person, we respond in a team of 2, so that includes 1 crisis counselor and 1 peer engagement specialist. So kind of being able to provide that mental health support. We really value our engagement specialists here, so that's somebody with lived experience kind of in the mental health and substance use world, that's really be able to kind of willing to share their story and kind of draw from their own experience to make that connection with the folks that we're going out to see. So yeah, thank you kind of for the patience and going through some of that and helping to set the stage a little bit for the panel and ongoing conversation that we're going to be having. So to all of you, I'd like to ask each of you to say a few words about your respective role in your community and share your thoughts on the value of alternative crisis responses in our local community. Why do you think these responses are necessary? And Renee, can we start with you?
Well, I believe they're necessary because the people that we're dealing with who tend to have mental health crises are our neighbors. And we understand at that moment they need help, and it's not help that would just send someone to jail or to deal with a police intervention.
I'm James Cappleman, the Alderman in the 46th Ward. Prior to that, I was a licensed clinical social worker. I started out my job as a social worker working with people who had HIV, who were diagnosed with mental illness, who had a substance use disorder, and who were experiencing homelessness. when I was working on my MSW, I remember coming across a reading that said that the Uptown community has the highest per capita rate of people living with mental illness than any other community in the United States. And so there's clearly an obvious need, and many of these individuals, for a myriad of reasons, are not accessing mental health clinics. They get their primary care from the emergency departments, and that's where they interact, or with the criminal justice system, and it's just not working. And it's much more cost effective to provide an intervention with your team, the FACT team, and it's much more holistic. So I'm a huge supporter of it, and I would guess that most of us know someone with a serious mental illness. You may not know it. I did not know that my dad had bipolar disease until he ended his life when I was a kid growing up. That's when I learned that he had mental illness. So we all know someone. It's just that it's a illness that we don't discuss.
Yeah, thank you. I think that's sort of speaking to some of the stigma around it, right? And sort of what some of the barriers I think can be sometimes to folks seeking out the services.
Good evening, everyone. My name is Melissa Sacluti, and I'm a deputy chief with the Evanston Police Department. We border Chicago to North Care. I think that alternative responses are hugely important. The police are understaffed nationwide, and we just don't have the amount of officers to deal with a lot of the calls. But even more importantly, when it comes to issues of mental health, we are not experts in this field, although we receive a lot of training on how to deal with people that are dealing with a mental crisis in that moment. Being able to pass that on to somebody who is certified and more expert in that field, I feel usually tends to have a better outcome. I think for us, the police are involved sometimes in moments where we're not necessarily needed. Of course, safety is our number one concern, and safety is an issue, then of course we're going to be involved. But in other more routine cases, when an expert can come out, a social worker, a crisis intervention worker, can help and help with the situation, I think that's far better than the police being involved.
To me, the kind of engine of problem at the core of what we're talking about is just the extraordinary inadequacy and the extent of the gaps in our mental health care system. And because of those gaps, people experiencing crisis traditionally have been pushed away from the care they need, right? They get put on a path in a different direction, a path toward self-medication, a path toward codependent relationships, a path toward criminalization, a path toward something other than the care that they need. And a properly constructed alternate response system is a way to identify people at a moment of crisis and then direct them on a path toward connection to the services they need and toward a humanistic and holistic recovery. And I don't want to pretend that Trilogy can do that alone, or a 988 number can do that alone, or a single van can do that alone, but this question of what happens at that moment of crisis, and do we use that moment as a spur to nudge someone in a direction of care or away from care, I think is a really critical question, and that's why this topic is so important to our whole community.
Thank you all. Yeah, and I think you're totally right. It takes a village, as they say. I think we all need to be able to kind of be part of that conversation of how do we support each other and support folks when they are having mental health crises. So I'm going to move to our next question. So to ensure the success of programs like FACT, it's important to raise awareness about them and be able to build those strong partnerships, as we were just talking about. So I want to talk a little bit about collaboration for a little bit and what that has looked like, kind of the vision for what we would like that to look like. So the next question is, can you share how you or your team's participation has been in the first year of FACT? How have you or your teams used the program or seen others like us in action? And Deputy Chief Sacluti, can you start us off?
Sure. So within the past year, we have collaborated with Trilogy and some of the crisis workers. It started at the beginning of last year where we had some of the workers come and spend time with our police officers, and we took baby steps with that. First, they would sit with an officer kind of side by side and listen to the radio traffic. So dispatch would dispatch a call. The officer would explain what that call is. They would listen to what that was like and then listen to what the resolution or the disposition was. And then we took it another step, and the officer would then take the Trilogy crisis worker on a ride-along. And that was more of a hands-on, but also just kind of an observational period. And the worker would come out with the officer, they would respond to a call, they would kind of watch the officer and how the officer was doing with that type of call. And then they would have kind of a mini debrief after that, just to talk about what the options were, why we took the action that we did, what was going on, in our mind, what other resources we could have used at that moment. And now we have not so much a dual response, but what you saw up here earlier, where an officer can get to a call and they will assess the situation. They have the option to call Trilogy directly with the 1-800 number, or sometimes they'll have our dispatch center call Trilogy and then somebody will respond. So the collaboration is there. I think, it's every situation that we respond to that is mental health related is very fluid. They are all unique, they are all different, and so something that can start out as something that's very calm, somebody just needs a resource, they just need help, can very quickly turn into a violent encounter. And so I think for us on the police end, it is a constant battle of, okay, first of all, was there a crime that was committed? Is this person, can they be looked at in a way where they need to be arrested for something? And balancing that with the safety. Not only the safety of the person that's having the crisis, but the officer, maybe any responding partners, and the community at large. So at any given time when the police officers are responding to calls like this, those are the things that he or she are struggling with and trying to balance in that to make the right course of action.
It's great, yeah, thank you so much. I feel like it's been great to be able to collaborate some with you. Every good question.
That was a very nice setup for explaining how this moved forward. And so what I was wondering, in medicine, we'll do, after a case, if we have a good outcome, we'll do a review of that case, and then we try to piece together what could be done differently, any lessons learned. So in the course of bringing the total crisis teams into these situations, have you gone through that kind of a process of examining when it didn't go right, and then learning from each other?
Yes, I think in any situation that we deal with, whether it's mental health related or not, but any call for service that we respond to that, maybe the officers could have done something differently, or maybe the supervisors that were on scene could have done something differently, there will be a discussion. It's difficult because we are expected to make very quick decisions with very limited information, and we have to make sure that on top of all of this, we're ensuring everyone's safety. And so when things go south, they go south pretty fast. And then we have to also understand that police officers we're reactive. So we are reacting to what is happening in front of us, all the while battling, is there something criminal in nature that happened? How can I keep myself safe? How can I keep this person safe? How can I keep the rest of the community safe? And also making sure that we're within the letter of the law. So in response to your question, while battling all of that, there are times that we miss debriefings. There are times that serious situations have occurred and we need to talk about it, but because of the day-to-day operations, we don't necessarily talk. But Commander Sullivan is an example of having debriefings, making sure that he checks in with the officers. They talk about what they could have done differently, if anything. And they will also highlight what was done perfectly, what was done well, or things that we need to work on. And we are constantly checking with our officers and supervisors to see what additional training we could send our officers to in various aspects of the job.
Thanks, and I'll just say on our end too, I feel like we do a lot of debriefing after calls, especially kind of more complicated ones, to be able to kind of review and see, yeah, is there something we could have done differently? What went well? It's good to be able to kind of spend that time and honestly to be able to check in with the staff and kind of see how they're doing, making sure that we're kind of providing the support in that way as well. Does anyone else want to kind of speak to what collaborating with the Trilogy team has been like, or I don't know too if you can share any of a time when maybe you wanted to have some sort of emergency mental health response and normally would have called 911 but kind of hesitated to do so because there wasn't an appropriate response available.
I run a business in the neighborhood. It is a neighborhood business, so we see many people daily, and with many of those people we can tell when maybe somebody is self-medicating or is not on their meds. And pre this 1-800 number, for example, we had one of our regular neighborhood people who was very agitated. We were trying to calm him down. They started to had a bag of clothing, started throwing it around, and we knew at that point we didn't have to do anything to call the police. Unfortunately, another customer saw this and felt unsafe, so they chose to call the police and said, I'm calling the police, which really just made this all spiral out of control to where he was throwing furniture and stuff. But again, at that point, he didn't need the police to come to deal with that because it wasn't necessarily criminal. With our staff, we have taken de-escalation classes. With Trilogy, we've also tried to daily keep a log of anything good or bad that happens and making sure that the proper responses and questions are asked of the staff on how they've dealt with something, if perhaps they need to see someone for counseling after something happens. Because it's really a whole situation and not just one person having an episode. And like you were saying earlier, you have to take the stigmatism out of it.
Yeah, thank you. It sounds like it's kind of giving you another option of something to call to get some support. Yeah, which is good.
When I was first elected, I remember speaking to someone who was running a library, the Bizazzian Library, and he casually mentioned that there was a table of individuals who were experiencing homelessness, and they would come in every day and just sit around this table and gather and just kind of mill around with nothing to do. And I got Catholic Charities to provide a social worker that helped, but the problem was Catholic Charities stepped out and Trilogy stepped in. I'm a very, very strong believer that we need to have social workers in libraries because there's a lot of people experiencing all types of trauma, and that was a profound thing to see happen. The other thing is, in the Uptown community, we have 6 homeless shelters. We have more homeless shelters than what we find on the combined all of North Side. And we also have 2 encampments that are rather large. So each ward was given $100,000 to fund any project that they wanted to see happen. And we did 2 pilot projects addressing chronic homelessness. And what we found that a disproportionate number of individuals living in the viaducts have an Axis 1 mental illness. So Trilogy took on one of those pilot projects, and we had Heartland Alliance take on another, and we compared the outcomes. So Trilogy focused on housing individuals for a week in a motel, and they would do intensive case management with the goal of getting them into permanent supportive housing or moving them in that direction. Heartland Alliance would have them individuals stay in an apartment for a set time period, and their goal again was to get them into permanent supportive housing. And oddly enough, we found that both projects were very beneficial in different ways. the Trilogy project was really beneficial for people who were very resistant and scared to accept services. And they would respond more readily, especially if the weather was getting very, very cold. And we found that that was an important key element that we didn't see anywhere in the city. So hats off to Trilogy for doing that. And then our staff, we have people sometimes just kind of wandering around. We have 4 nursing homes for people with chronic mental illness, and we have a facility for people with mental illness who are also active substance users. And the goal is people who actively use, they still need housing, because if you don't house them, they go to the ERs all the time, so it's extraordinarily expensive. So when we do see people in a crisis, it's just not appropriate to call 911. And some of these individuals have had very bad experiences when they see a police in uniform. And I remember once doing that. I saw an individual in the alley that was very sporadic. I know him, he's got chronic schizophrenia. And at that time I called 911 to get 2 CIT officers out, and which is good. We want CIT officers, crisis intervention trained police officers. But when the individual saw the 2 police officers in uniform, he ran and started running in the street. And so the police officers stopped. They don't want to get this guy hit by a car. But I'm convinced that someone like the FACT team could approach that in a way where it wouldn't scare him, because the fact of the matter is this man, seeing anyone in a police uniform is going to frighten him. So that's why the FACT team is so important.
Yeah, great, thank you. I think you're right. It's less intimidating, right, to just have someone come up in plain clothes and check in and see how somebody's doing. Where I think a lot of people have had trauma and other experiences, or been institutionalized for a long time, which makes them react in different ways to different people.
I think Chief Sacluti answered the question comprehensively from Evanston's standpoint. I would just, make explicit what I think is probably pretty obvious, which is that, we have a overworked, understaffed police department, and here we are outside of our municipal borders with a deputy chief and a commander here. I think it's a reflection of how seriously our police department takes this partnership. It's one that we view as really essential for us. We view the work as essential from the point of view of our core mission for our community, and we view the partnership between the organizations as essential to make the work go right.
Yeah, great, thank you. And I will just say too, that we work really closely with CPD, with Chicago Police Department as well, and their CIT officers, as Cappleman stated. They come out and help us out in a lot of situations where we do need kind of that additional support. I will say it's been a little bit trickier in some ways in working with the Chicago Police Department, just because they're so huge. And so a lot of the legislation that has changed with the recent, or over the past year, kind of that mobile crisis response piece, they've not had as much or it's just been a little trickier, I think, to develop some of the policies and protocol and that sort of thing. So they're still working on that, and we hope to kind of be a part of those discussions with them and continuing to build that relationship there as well. All right, we're going to switch gears a little bit to give you some data. I don't know if you all have the flyer and handout that has some of this data already, but we're going to stick it up here and talk a little bit about sort of what we've been doing over the last year and what some of those numbers have looked like. Overall, over the last year, we've had about 4,000 calls from around 1,000 unduplicated callers. So it's a lot of people calling the line, a lot of times of us responding and going out. So around 600 initial crisis mobilizations. So that's that initial call that we get. We screen, as Mimi said, it is often her that is answering the phone. Kind of checking in, getting the information from them, trying to get an idea of whether it is something that we can talk with them over the phone and kind of provide the support in that way, or if it's something that we want to go out and do further assessment around. So about 600 of those initial in-person responses. And then over 2,200 follow-up appointments. And this is something that I'm really proud of. I feel like the crisis team initially was kind of set up as that we're going to go out, kind of check in and see how people are, make sure that they're safe, and then we're out of there, right? And I think that, yes, that is the primary response of the crisis team, but a big part of that to me too is that what can we do or help put in place to prevent that crisis from coming up again? When someone's working with a crisis team, we have about 30 days from that initial opening them up to services to be able to provide a little bit of follow-up and ongoing care. And so we take that really seriously and try to think about, hey, what referrals could they use? Maybe it's other services within Trilogy, maybe it's a referral to somewhere like Tapestry to make sure that they are connected with BCP and ongoing psych, or an outside therapist if they don't have Medicaid. It's really kind of, I feel like our staff are really good at kind of getting in there and what are the needs, can we get them signed up for Medicaid? We're really trying to figure out in that 30 days, what are some things that we can do to help put some resources in place for folks that hopefully prevents them from being in crisis. I do think sometimes people continue to call because they develop those relationships with staff, but a call in that situation is better than a crisis call, for sure. And then around 1,000 or so just general inquiries too. I think some folks that are looking for services or looking for resources will reach out to that line, and maybe in some ways it feels a little less intimidating or they feel a little bit more anonymous in being able to get referrals in that way. This is another statistic I feel like we are really proud of. So over 90% of our engagements happened without needing to call 911 over the last year. And this number is kind of all of the engagements included in that 90%. So that includes kind of our follow-up appointments and that sort of thing. I will say for that initial mobile response, that number is probably a little bit lower, just because sometimes there is more crisis where we do need that support from police or from other folks. But we really try to go out and assess the situation, provide de-escalation and whatever kind of supports that we can. And make sure that they're safe, and then kind of move on from there. So I want to talk a little bit about the demographics of folks calling and kind of what that looks like. So overall, you can see about half of the calls that are initiated have to do with addressing serious mental health issues. So kind of that psychosis and suicidal ideation are kind of the biggest ones that we see. But then there's a lot of other ones that you can see on there too. Sometimes it might just be a wellness check. It might be folks kind of experiencing a traumatic event. Substance use is another big one that we see, of kind of just going out and checking on folks and seeing how they're doing. So it is kind of a wide variety of different things. In the video, Caitlin also kind of talks about just that, I think we were surprised initially to see that a lot of the calls kind of came in for more like environmental stuff. So things like people experiencing homelessness, kind of needing just that support around resources. I think when most people think about a crisis line, you think about suicidal ideation. That's kind of immediately where your mind goes. But there's a lot of other kinds of crises that people are experiencing that we want to be able to provide support around as well. This kind of gives us a breakdown of who's calling the phone number, or calling our fax team. It's a wide variety of that as well. About 37% is the person calling for themselves if they're experiencing a mental health emergency or just kind of need that ongoing support. But then, as you can see, it's a big piece too. That is family members that are calling, kind of concerned about a relative or family member just wanting to ask us to do a wellness check or kind of even get some resources and support and advice kind of around how to handle different situations. Community organizations, I appreciate some of our partners being here tonight and being able to work closely with them when things come up. Police, we've been able to work really closely with as well. And then hospitals, Maria and Cappleman both, we work closely with you guys too and respond to calls sometimes with folks kind of around those offices as well. This gives the breakdown by neighborhood, what that looks like. Rogers Park and Evanston, one of our biggest ones over Alcohol, and then Uptown's around 14%. So yeah, I feel like kind of right around here is probably the majority of them, but then that other one, I think a lot of times is sometimes folks calling from outside of our area, so then kind of trying to follow up with partners in those areas that maybe are able to go out and provide the response that is needed. This looks a little bit more in depth at the demographics of the callers across the past year. So age tends to be kind of that, 19 to 44 range is sort of our biggest age group. In terms of race, kind of white or black and African American are kind of the two bigger pools of folks. And then with gender, we tend to kind of lean a little bit heavier on folks that identify as male. I think these are some other stats that are just interesting to me. I think that we see in the city and kind of know that there is a lack of affordable housing across the city. This kind of gives us about one in four of the folks that we're working with are experiencing homelessness, and kind of just really trying to link folks to resources, help kind of figure out what we can do to help get them what they need. But unfortunately, we need a lot more resources, I feel like, in this area, kind of across the city. And then the uninsured and Medicaid. So we do bill for Medicaid here, bill for our services for folks that have Medicaid, but we serve anybody, whether they have insurance or not, coming in through the front door or coming in through our FACT program. And so really wanting to kind of make sure that folks that are uninsured are being able to get linked to Medicaid. I think that's like an area of advocacy that we've seen too, is just that a lot of private insurance plans don't pay for crisis services, but we all know that folks from all walks of life experience mental health emergency and mental health crisis. So kind of an area to hopefully increase funding in those areas with private insurance to be able to help pay for some of those services as well. All right, so thanks for kind of sticking with me through all of that data. We want to get a little bit of feedback from our panelists around thoughts on that first year of data. So let's check back in with you all. What are your responses to the data and these results? And Alderman Cappleman, can we start with you?
Sure. I mean, clearly there's an intense need for these services. What I've also observed, I mean, I think it's about close to 24% experiencing homelessness. These individuals, if the other 76%, if they don't get that help, they will go down that path to actually experience homelessness. And what we do know is that it is cheaper we actually save money. We save taxpayer money by providing housing with support services than having someone live on the streets. It is actually cheaper. And so it's paramount that we focus on all those people in need, because we don't, well, one, they need it, but we also know that if we don't do it now, it gets more costly later.
Simply put, I'm very impressed by the data. 4,000 calls in a year, I mean, that's 11 calls a day, that's pretty impressive. I appreciated especially the pie chart slides on, who is receiving the service, why are they receiving the service, and also I'm a little bit shocked by the where are you responding to for the service, and you'll see that Evanston's at the top of that, which just tells me that the partnership is extremely important, so I appreciate it greatly.
I just have to add how important partnership is between both Trilogy and the police department, and like I said before, we can see these people on a regular basis. Even the police in our neighborhood know who, for many situations, what is an episode where someone needs to, if there's a criminal action or there is an action that Trilogy should help step in.
The only thing I'd add is, let's just remember how gradual the community education about a program like this is. And so when you think about how enormous those numbers were in year one, that, I think, we all need to assume that represents a tiny fraction of the need, which is probably kind of consistent with our intuition, but just both sobering and also, for me, really, really motivating as we think about this work.
Yeah, thank you for that. I think that's been interesting for us to see, even in starting out, not being 24/7 and moving to that, and just, yeah, kind of the ongoing need. And as we hire more staff, it just feels like we keep getting more calls. So, yeah, it'll be interesting to kind of see over the next year what that growth continues to look like. So, FACT provides a mechanism to respond to a crisis other than calling 911. To paraphrase Trilogy's crisis counselor, Caitlin, when FACT responds, we don't come with flashing lights and sirens. I feel like this is a little bit of what Cappleman, you were kind of saying earlier, but how does this help to reduce stigma around mental health? Mayor Biss, can we start with you?
Sure. And there's a lot of data, by the way, to back this up. That, and by the way, DC Sacluti referred to this earlier, and I want to really emphasize this. When we talk about a police officer not being the right person to respond to a mental health call, that's not a shot at a police officer. That's just a statement of fact about the education and training that individuals in our public safety systems received, and what they haven't received, what they signed up to do and what they didn't sign up to do. So there's a lot of data out there that shows that when it comes to the project of seeking somebody experiencing a mental health crisis to accept services, having a trained mental health professional is on average more successful than a police officer, and yet more successful still is a peer. And so part of this is about the stigma that is created for a third party, for the rest of us kind of watching the interaction or seeing someone show up with flashing lights and a badge or not. Part of it is what the experience of the person in crisis is as the service is delivered. And that moment can be so pivotal, again, in determining the path the person goes down, determining whether the person then seeks out the treatment they need and the care they need, or whether the person retreats into a warren of non-solutions that can exacerbate the problem, or at least allow the problem to fester and worsen without care and treatment. So it's really important, and it's just important from a standpoint of fit. We live in a complicated world, and we live in a complicated world where most problems that we call upon people to solve are not solved by everybody. But to treat mental health crisis as a complex problem that requires sensitivity and care and training and professionalism to solve, it's factually correct, like it's a true thing, so it's the thing we want out in the world. It contextualizes the problem appropriately for the broader community, and it makes the person in need of services likelier to feel like, okay, here's something coming toward me that I'm prepared to accept, not something that's going to make me feel like I'm being somehow marginalized, called out, having a finger pointed at, or otherwise treated in a way that's going to want to make me retreat further to my shell.
Any other thoughts from you around how that response from folks in plain clothes and just going out and kind of talking to people helps reduce stigma of mental health issues in the community?
I'll just say that, that I'm not ignorant to the fact that, this uniform means a lot to people, and some people are very intimidated and scared by it. I've always been very mindful of that throughout my career. The response with Trilogy, not responding with lights and sirens and things like that, is hugely important and can be an advantage. Speaking from experience, there have been many times that we've responded to calls and the family, mental health calls, and the family will say, don't turn on your lights and sirens, please. And the dirtier truth about that is today we live in a world where whenever you see the lights and sirens, rather than helping the person that actually needs help, They are more concerned about videoing what we are doing. And this too can create major problems for the person who's actually seeking help. So I look at it in that way too.
The whole sense of stigma that exists, we have to reduce it, because when someone with mental illness believes that they are a defect, that they're not going to get the help they need. My dad did not get the help he needed, that he desperately needed. And so we have to do everything we can to reduce that stigma. And just imagine that you're having a mental health crisis and someone is observing it and they call 911 and the police respond. Imagine what's going through your mind. I did something wrong, I'm bad, which is not what we want to communicate to someone experiencing mental illness. It's like, we don't do that with someone diagnosed with cancer. Why do we have that? But we do. And so it's important that we find ways to respond to people in a crisis so that they will become more willing and motivated to get treatment. They can get rid of that stigma that I wish my dad did not have it, but he did. The other thing I liked about it is that when we observe someone experiencing mental health crisis, when we call 988 or a FACT team, it also educates us, because it's not just the person with a mental illness who believes there's a stigma. We all have that, and we all need to deal with that stigma. And so I think as we deal with that stigma, we'll improve the way we provide mental health care, because we all know there's a lot of work to do.
The one thing I would like to add to that is that, as you were saying, it appears to be more when a peer is showing up as opposed to a police officer, and there are people always waiting to put their video on. And when people are watching how we are dealing with the people in our neighborhood and how we're reacting and helping someone, I feel that sort of rubs off on the people around.
Yeah, that's a really good point. Thank you all. And I think it does speak to even, having nights like this, being able to talk about mental health issues in our communities helps break down the stigma as well, right? And kind of that we're all a part of the process and journey towards breaking down that stigma and kind of how we treat each other, how we treat our neighbors, just kind of how we interact with folks that we're seeing is all kind of contributing towards hopefully breaking down some of those barriers. So I want to just highlight a few of the key takeaways from tonight that we have talked about. There's a variety of different factors that influence that development of crisis situations. We all know that a crisis is more than just that one moment in time. It really is kind of a whole process, right? Usually we get brought in that moment of time when someone is feeling really overwhelmed and unable to deal with what's going on with them. But there's usually kind of a build up to that, as well as kind of like a letdown from that. And so to me, again, that's kind of that piece of having a little bit of time on the other side too, to hopefully help folks build some of those coping skills, get those resources, to feel like they've got what they need to be able to deal with it when they do feel overwhelmed. Again, and then we know that a lot of times crisis it's sort of that wave. It's like it has its peaks and valleys. There's times when things are worse than others. And kind of seeing it as a process, I think, is kind of how we usually respond in the moment. We know that a lack of accessible mental health services now absolutely can lead to crisis later. Kind of as Cappleman talked about, kind of things can get worse over time if we're not able to deal with them in the moment and kind of help folks get those resources. I think there's a lot of research around preventative care really being something that helps folks stay better and more well throughout their whole life. And so if we're able to kind of help folks get the supports earlier on, there's a lot better chance of greater outcomes at the end. We also know that youth and adolescents and families are facing an especially challenging time right now regarding mental health. I feel like there's been a lot of research and studies, you've probably seen it on the news, just that youth mental health rates have been really high lately, and kind of I think a lot of that has to do with the pandemic and folks kind of bouncing back from that, but just there's a huge need right now around more support needed for that specific population around youth and adolescents. And that's something that we've really tried to kind of build up in services here to be able to provide more therapists to provide services to that population. So these are kind of some of the other things in addition to our FACT program that we are working on here at Trilogy. So really trying to work on providing that post-crisis support. Again, as I talked about, those follow-up appointments, really kind of working with folks either to get connected to other programs within Trilogy or even just being able to kind of work with folks throughout that 30 days to get into things. We continue to grow the FACT program as well as agency staffing, wanting to make sure that we've got enough staff to be able to respond to the calls that we're getting and to be able to go out as needed. And as I said, we've been increasing access to therapy for that children and youth population and ensuring that that they have access to folks that are Spanish speaking so that they can get services in their own language. One of the other things that we are really excited about is we bought a building, as Susan mentioned, in the Chatham neighborhood at 85th and State Street. I feel like we have for a long time been talking about wanting to be able to provide the same level of services on the south side as we do on the north side. And so the vision for that building is really to kind of build it out in a similar way to services here in this building. So having a drop-in center, having groups, therapy, our outreach teams, so our sort of community treatment and community support teams that are able to go out from there. Just really trying to bring a lot of the services, hopefully having a partnership with an FQHC or federally qualified health center out in that area, as well as the pharmacy will be out there. So yeah, just really wanting to build services to folks on the south side as well to be able to access services in the same way as they would if they were on the north side. Thank you again, everyone, for participating tonight. Any questions that we have from the audience?
Hi, my name is Kelly, as I introduced myself earlier. I support Trilogy's crisis phones. I'm with T-Mobile. And I guess my question is, as far as technology goes, is there anything I can do better than what I've already done? I make it a mission to try to make it as low cost as possible, to not take out of the overall budget in providing devices and network access. But basically just looking for any insights of any other either relevant technology we can donate or participate in that would help, or feedback on the current technology, as well as any way that we can be better, do better.
I'll say this. For people experiencing homelessness, the federal government has asked all social services to every time they interact with someone, they put them in the HMIS system, Homeless Management Information System. And in that way, we can track all those people who are getting services. And now we're in the process of using that information to do a deep dive analysis to see what is working well and what is not working well, so that we can start tweaking our interventions to get help sooner rather than later and do it in a more comprehensive manner. What I discovered 2 weeks ago is that hospitals and Cook County Jail do not use the HMIS. And for people who are most resistant and are going from crisis to crisis to crisis, it's either the emergency room or Cook County Jail. And the problem is when it goes to the emergency department and they're having a crisis, the hospital doesn't know where they're getting services, so they can't contact that social service provider. And sometimes the person getting services either doesn't know who their case manager, maybe they have schizophrenia or disorganized features, and they just can't come up with that. I would love to see technology, this may be outside your realm, but this is my dream that I'm bringing up to Department of Family Support Services. My dream is to be more coordinated and collaborative with the hospital system and the Cook County jail system with the social service system so that we can provide much better care.
Yeah, I like that. You got the wheels turning, okay.
Okay.
Noted.
Okay, I have my card if you need it.
I do.
Good.
Thank you.
Yeah, I have a question on that note as well. Is there cooperation amongst all of your areas of specialties, whether other mayors and other aldermen and police and business owners, that there is other types of databases or information sharing that might aid a patient at some point, or is everybody sort of working independently?
I will say this, this is my passion.
Yeah.
What we know, what we discovered from COVID is something that we already knew back in the early 2000s when the federal government required all cities to develop a plan to end homelessness. And I'm talking about homelessness because a disproportion of people experiencing homelessness have a mental illness. What we find is we work in silos. And it's that if you really want to address a systemic issue like homelessness, and I've talked a lot with Denise Parker, she's the former mayor of Houston, Texas, and they were written up in the New York Times by doing a phenomenal job of addressing homelessness. She said the number one key, the first thing that you have to do, besides getting more housing, not just housing, you gotta get housing for people earning less than 30% of their median income. But besides that, which is a huge piece, is you have to get everyone working in a coordinated and collaborative manner. And if you do not do that, you will keep spinning your wheels. The problem is our system is set up to encourage social services to work in silos because we're competing for grants. So we're trying to change that where we provide grants that call for coordination and collaboration. I think we have to do a much better job with the HMIS because HMIS, I imagine Evanston has to do HMIS as well. So everyone does it, and so that's their database. That's the way to do it. The problem is social services has been dragging their feet a little bit. But because they're overworked, so I'm not blaming them. And we're not doing a good deep dive analysis of HMIS so that we can understand more fully what's working and what's not working.
I just wonder if you could comment a little more on your response options of fact between the immediate on-site assessment, de-escalation, and maybe follow-up appointment, and on the other end, possible hospitalization. What do you have in between? Can you transport? Do you bring people here? And then another quick question. It's about 988. So the very small number of your referrals that come through 988, and I understand it's a work in progress. Could you comment on just on what that about? Is that a political issue? I understand there's local funding issues with 988. So just a bit about that.
Yeah, I can take the 988 one, and then I might pass the other one off to Katie or Caitlin or Julie or anyone that wants to speak a little bit. They probably have more details than I do about the calls and kind of what they see there. But with 988, I think part of it is just the system getting switched over and kind of getting all of the bits and pieces into the logistics of how that's going to work. I don't know, we probably have gotten, 10 or 15 calls a month? Does that sound about right? No, that's large. Okay. So less than 10 in a month so far with 988. But I kind of see that growing as some of those logistics get put in place and more folks are aware of that 988 piece. I just feel like there hasn't been a ton of marketing around the 988 being a thing and people knowing that that's an option. So I'm hoping that as people become more aware Park, more of those calls are ones that we get from there. I think we've done, to be honest, we've done a decent amount of marketing around our specific crisis number too, and so that probably has something to do with getting calls in that way. There is a specific form though, so when we get a call from 988, it's usually one that has already been screened by 988 that gets sent over to us to say, hey, this call needs an actual mobile crisis response. I know there's been a couple that have come to us that really are outside of our area. I think that's still a piece that's getting worked on too, where making sure that the 988 response have the right kind of grid of the city and who has what neighborhoods to be able to call the right agency. But so we've done some responses, and then there's a specific form that we're supposed to fill out that gives the information of what that call was, what happened, to be able to then send that back to the agency that handles the 988 calls. So there's a little bit of a feedback loop there that I'm hoping will help with that process over time. Did that answer your question about 988?
Yeah, is there, my understanding is that there has to be state appropriation for funding for 988.
Yes.
Does that cause a problem?
I don't know if I would say it's a problem. It's just, I mean, I feel like right now there is an agency that's called PATH that handles all of the 988 calls. So I think it's taken them a little bit to like get up to speed, but I feel like in terms of funding, that part seems okay to me so far. I think in other, maybe more rural areas of Illinois and across the U.S., I think that is definitely a problem of just the call centers themselves, not having the staff and then the funding to kind of get up and running too. Yep. And then Katie, do you want to kind of respond to his first question?
So in terms of how we can work with folks that call us, we have a lot of freedom here, which is really nice, and I think that that's sort of born out of Trilogy in general. Historically, we've provided a lot of CST and ACT, like community work for folks, so I think we're really gifted at being creative on how we meet with people, so we go to their homes, we can meet them, even just on street corners. We've had repeat calls for folks that are, maybe spending a lot of time on one area or one park or something, and we've been able to slowly build a relationship with them over time. We have a lot of flexibility with client assistants to take folks out for a cup of coffee so that it's not, so sterile and hospital focused. And that is something that we're able to do, take somebody to the hospital in our van so that they're not riding ambulance. And then we can take them here. Partnership with the Beacon has been really helpful to help engage people getting a meal, having a place to hang out, so that they're not just solely focused on what's wrong with them.
This has been really uplifting. Thank you all. It's been good to learn about this. And as I listen to the mobile crisis team here through Trilogy, and I know Threshold has one, we have the folks here from Oak Park with theirs, and Lutheran Social Services is doing this also. So it almost sounds like there's going to be like catchment areas where folks will be covered by one of those agencies, which I think is ideal. So then I wonder, why is Chicago building a CARES program where their folks will be responding? Why would we go in that direction?
I will say I think the CARES program kind of was one of the pilot programs for the mobile crisis response. So I think that going well has helped to then fund a lot of these other programs across the city to be specific to the different agencies throughout. So I think that was kind of a good pilot program that worked out really well, that kind of taught us, yes, this is what we want to do, and helped us secure other funding to be able to build those programs out. Also, currently the CARES program is kind of like what SAS used to be. I don't know how familiar you are with that, but it's the responding to kids, to children that have Medicaid, to be able to kind of do that assessment with folks of whether they need to go to the hospital. So it's kind of a little bit more of a specialized team that the CARES program works with now to go out within a certain time frame specifically for those kids. I don't know if that totally answered your question. We are in a lot of different meetings and collaborations. There's a lot and lots of different meetings with other providers, of other 590 providers, with the CARES team, with folks from the city of Chicago that are funding some of the crisis response stuff. So I think part of it is really at this point trying to build that infrastructure across the city, across all of these different providers, to really make a robust system. And we're kind of fumbling along with it. I think we're further along than we were a year ago, but there's still a lot of work to be done to cover all the areas, to make sure we're communicating well with each other, communicating well with the city as well. There's still a lot of growth to happen.
I can also add that the 19th Police District has a CARES team, and there's a police officer and a medical technician and a social worker that are part of that. And that team goes out if it's been identified that there is some threat of violence or a weapon involved. If not, then it's much more appropriate to have something like a response from Trilogy or Thresholds. We have Trilogy, Thresholds, and the CARES team all in the Uptown community.
How does the crisis team determine when they need or want police support? I think it really depends and is really individualized on the actual response to the situation. I think when the call initially comes in, it's really trying to gather as much information as we can about what's going on with them, and kind of what the appropriate response would be, right? So if there is something like a weapon, then that is an automatic 911 call to go out with us. I think a lot of times it's once we get there and are kind of doing that assessing, and one of the reasons why we have two people go out is to be able to kind of see what's happening and make that assessment once we're there. And again, it really comes down to that whole kind of piece of are they safe, right? Are they a threat to themselves or others? Usually, if that is the case, that would be when we would call 911 and kind of go through that petition process if that's what's needed at that time. If someone kind of needs the hospital at that point and they're willing to go and you kind of have some insight into what's going on, there are times when we will transport at that point in time, but I think it's hard to say, I guess, like exactly when we would know for sure, because it really depends on the situation itself. But the safety piece is really kind of when we mostly need that additional support from police to be able to come with and make sure that both the client and our staff are safe in that situation. We do too. There are, a couple of buildings kind of across our catchment area that maybe just have more going on, kind of around there. So there's also times when it's just been like, I don't know how safe it is for our staff to go in by themselves, so we might call police to be there and be around, and we'll go in and sort of assess, but then we know they're kind of right there if we need them. Thank you so much, everybody, for participating.